Hello and welcome to our virtual rhinoplasty meetings. My name is Dr Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. For episode 11, we're moving to Turkey to listen to Baris Cakir giving us one of the most amazing talks I've ever heard about the tip in preservation rhinoplasty. Whilst you just take a break and the questions come flying in on YouTube and on Zoom, I just want to mention to everybody on the forum that Amir will be sending out, he's just sent it now on the chat group for the CME points. So if you want to fill that out and you get your certificate, please do that. And we're also running the survey. So anyway, let me crack open the questions and scroll them through. So a lot of your friends are writing in Turkish to say you haven't shared your screen at the start. But okay, we've got all of that.
Turkish questions. Okay.
And let's get down. Okay. So Ahmed wants to know how to preserve Patangi in open approach.
I never preserve the Patangi ligament in open approach because many years I do primaries in close. So I know Teoman Doğan and Abdülkadir Göksel is preserving the Patangi ligament in open approach. What do? You open the flap. Okay, when you reach to the Patangi, what you can do, you can split into the middle, but you cut the body and you go and you do dorsum surgery. But it's a little disturbing. But the main thing, you preserve the scroll ligaments laterally. Okay. But a lot of surgeon is doing that. You are not opening the scrolls, and you are opening only Patangi ligament. This is a complex, okay? 2 scrolls, 1 Patangi. Also, what you can do, you can open the scrolls and left attach the Patangi. You can go laterally, do your dorsum surgery. But if you can do dorsum surgery from the laterally, okay, you don't need to cut the columella. You can do the tip surgery with direct vision, but good delivery technique, you can do tip surgery like open approach.
Awesome.
But start preserving with open approach. Why not? It's the good.
So Filio in Belgium wants to ask you. She says, "Do you turn your rim flap over, under, and how?" Many thanks for an amazing talk, Baris.
Rim flap, under or over? Oh, okay. Think about that's. Okay, that's lateral crural. Okay, when I decided to do rim flap like this, it will be rim flap. Think about this is cephalic excess, this is caudal excess. You can do cephalic part under, over, or sliding, but you can't. I try, but it's not working. It's simple. Cut and suture the mucosa. Its position is like this. That's all. No underlay, no overlay. It's have to be free in the space, half a millimeter. Okay, it stays in the shadow, in facet. Okay, the position is exactly like this.
Awesome. Awesome. Okay, Ali wants to know, did you say that sub-SMAS is the gold standard technique?
No. Gold standard, no, I didn't say. In many textbooks, it says sub-SMAS is the common technique. Maybe it's gold standard technique, yes. People say dissect the nose. There is no option with the subperiocontrial. Maybe it's little new, but I didn't read it's gold standard technique. Only I tried to say I made a mistake at the beginning. I was thinking that subpericondyle was the normal dissection. I realized nobody is doing that in I mean, 2008, years ago.
Cool. Kian would like to know, where can you buy the 3rd edition of your book?
It's almost finished. Roland Daniel is editing the text. All the chapters arrive. We have new chapters about the dorsal preservation. Fausto, Miguel, Ishida wrote some new chapters. Also Carlos, and we revised some chapters. In 2 minutes or 1 minute, it will be finished. It will be ready in 3-4 months.
Fantastic. Great. Okay, Filio's got another question for you. She wants to know, what is the best ratio between the infratip lobule height and nostril height?
Okay, it's 1 to 2 maybe. You know, look, I'm pure left-handed. So my brain is not working with ratios, exactly numbers. I look the proportion with my eyes, like sculpturing. Okay, this is my good ratio. I look at the nostril and the lobule. Sometimes you see amazing noses with long lobule. Okay, you can't put a mathematic rules, because if you have a good or more angulated columellar breakpoint, and if your lobule is going high, still little longer lobule still is beautiful. Or your columellar breakpoint is lower than the nostril apex, so your nostril is little visible, or little higher than the nostril apex, your columellar breakpoint is more beautiful. Okay, there's I don't have a mathematical rule like that. Okay, I couldn't answer this question. I look at and I decide.
Great. Okay, Alexander would like to know if there's a way to get the file to 3D print the blue nose model, or if you have it for sale.
I sent this model to Medicon, Germany. They produced 10 only. And because it's became really expensive, one is $100, only production. So they didn't go on. So also we did make this model to produce a lot. I think in Istanbul meeting it will be ready. As you see on the left side, on my right side is operated. You see the rim flap. Okay, rim flap here. Other is the bulbous long lateral crural, convex lateral crural. This will be ready in the Congress. We will make producing with casting.
Fantastic. Thank you. Okay, Muti would like to ask if you do alar base reduction for deprojection noses.
No, I don't deproject the nose with alar base reduction. It's my consequences. I do my tip surgery. Sometimes I think the patient doesn't need a base surgery. With the projection, we create a flaring, so I do base surgery. I don't deproject the tip with the base surgery. If I see a big nostrils or I see extra volume at the base, I do nostril base surgery.
Okay, great. I'm just going to jump over to a lot of the YouTube questions. There are also many questions on YouTube. And a question here is, Ashab wants to know, please explain setback.
Setback means, deprojection, reprojection. It's a little confusing. If the terminology is deprojection, okay, what you are deprojecting? If you are deprojecting the nose base, okay, it's I do spine resection. The most powerful nose deprojection method is spine resection. First, I cut the spine, maxillary spine periost, okay, and then I dissect. Still doesn't enough, I resect the spine. So all the nose come back, okay? This is nose deprojection. If you are doing, setback, some people are describing with the setback, medial crural setback, okay? But the medial crural setback is decreasing the lobule projection. So what's your indication? If your tip projection is over projected because of the nostril apex, means base, do surgery, spine resection or spine dissection. Okay, if you have a hanging columella or over projected lobule, do medial crura overlap. How I do this? This is the medial crura, this is middle crura. I cut an oblique cut and I do this. If you want to treat hanging columella, to not decrease the lobule, I cut partial overlap, I do this. So also you can do both. First, treat hanging and do overlap, okay? Depending your indication.
Thank you. Okay, Khalid's got an interesting question. He says, hi, thanks, Baris. What is the purpose of scroll ligament repair and what is the resulting effect?
Okay. Look, think about your surgery. When you know, all lateral crura is very stable, okay? Cannot go up. But if you dissect the nose, if you push your lateral crura downward, upward, your lateral crura can easily touch to the keystone. What's the barrier to prevent that action? It's the scroll ligament. Scroll ligament is the stopping point or barrier point for the lateral crura, okay? Scroll ligament is attaching the lateral crura caudal border. If you lose this connection, okay, lateral crura jump over the lateral crura, or lateral crura jump over the upper laterals, okay? Also, what you lose, okay, you see that position, okay? If there's no scroll, also you lose resting angle, okay? First, with your tip stitch, you rotate the lateral crura. With the repairing the scroll, also you secure your lateral crura resting angle. Another point, scroll ligament is the insertio of the transversalis. Transversalis muscle is making an insertion with the scroll or by the scroll to the internal wall. Now, there is a thickness between the internal wall to the scroll line. After some surgery is getting thicker, okay? So look at the internal transversalis muscles. Oh, I'm making interesting mimics, okay? That's very strong muscle, right? Transversalis. When wrinkle your nose, take a breath, okay? That's, in some patients or some people, it's opening the internal wall, sometimes closing the internal wall, but it's obvious. We can say that transversal is stabilizing the internal wall with the scroll. So scroll is important for beauty and important for the function. So it's really important to prevent alar retraction, okay? If you push your lateral crura downward with the scroll, if you don't resect a lot with the lateral crura preservation, with rim flap and the sliding flap, you see the alar notching really rarely.
Okay, I've got two questions here in terms of the rim flap that I'm just going to ask together. Danilo wants to know if you cut all the way the perichondrium, the cartilage, and the perichondrium and the rim flap. And Shahan wants to know if it's far away from the facets, how can this support the facets?
How can? It supports, but I can't. Maybe I have to open the, okay, rim flap. A lot of people are asking. I can make a presentation about that in 2-3 minutes if you want, okay? It supports. It supports.
Look, we've got like another 55 questions and we've got 5 minutes to get through them. So focus, let's just answer a few of these questions as well as we can.
Doesn't matter, okay? If you incise and the left in place and suture the mucosa, okay? What's happening? Look, think about this. This is cephalic excess or this is caudal excess, okay? This is 4 millimeters. This is 4 millimeters. It's 8 millimeter narrowing. If you want to narrow the lateral crura 8 millimeter, what you gonna do? Okay, and you left the worst part of the lateral crura. Okay, that turning point doesn't work, doesn't create a highlight. Okay, what we are doing with the rim flap, and the less cephalic resection, I use the center, powerful center part. Okay, what's also important? Okay, that's the skin, that's the cartilage. Skin cartilage relationship is important also. Sometimes cartilage is close to the nostril. Okay, so if you left the cartilage close to the nostril, so you can't create a highlight. You need a space between the nostril margin to the lateral caudal margin. Okay, that's important. We need 7-8 millimeters sometimes distance. If you left the rim flap, that distance gonna support with that caudal excess. It's very logic. Maybe little drawing and sculpturing is important.
Okay, Baris, a few questions have come up in terms of how do you determine how many millimeters of lateral crural steel you're going to use?
Okay. I draw lines to the cheek to show that is showing the knee tip. Okay. If the tip is here and my near tip is here, I sit my chair. Okay, this is the lateral crura, this is medial crura. Okay, this is the forehead. Think about. This is the chin. I do still, and the tip is going up. If I still more, I lose projection. Okay, I place a pancet and rotate. Rotate. If I think it's too much, okay, I come here. Also, I stretch a little bit to treat the convexity. Okay, with that maneuvers, you stretch lateral crura and rotate the lateral crura close to the dome. You try to find knee dome. It's little sense, okay? But basically, we are still in my country 3 to 7 millimeters. Average is 4, 5. Okay, start with 2, 3. And you're going to understand the effect of the lateral crura because it's making rotation, increasing the lobar projection, loss of effect. Little sense, little experience, but not too much. 30, 40 rhinoplasty with stealing. Okay, surgeon going to understand.
Awesome. Okay, I'm going to unfortunately have only time for 2 more questions. One question, a lot of residents who've applied from all around the world. And I know there's people up in India, it's already tomorrow, it's past midnight. In Australia, the guys are also clocked in. A quick question is, what suture material do you use?
6-0 PDS, round needle. If you do lateral, we have thick cartilage, okay? So you can do subperitoneal excision easily. So subperitoneal excision makes the cartilage pliable. But if you do subperitoneal, don't squeeze with the pancet. And the second, don't use sharp needle. The best suture material is 6-0 round needle PDS.
Great. Okay, Baris, so the last comment. I know next week Rick Davies is speaking, but I'd love you to have some comments on septal extension graft. Yes.
Okay.
How often do you use it? When do you use it?
I think I never use septal extension graft. Never, because of the Pitangi preservation. Okay, I know the Rick Davis idea. Rick Davis is doing lateral crura still. Maybe we are doing the same lateral crura still procedure. Maybe he is doing different kind of stitch, but he is creating a tensioning. But he is creating a tensioning with the lateral crura, but pushing the domes with the septal extension graft. Okay. How I do that tension, maybe not perfect as the septal extension graft, but I have a septal angle, okay? And there's a soft tissue between the septal angle and the domes. That's 4 or 5 millimeters something. That's the Pitangi, okay? Rick Davis is straightening the lateral crura better maybe, but he lost the elasticity. Our tip is totally elastic as before. Okay, our patient is easily taking the tip up and down laterally, very mobile.
Sure. Well, Baris, there's another 53 new questions sitting here, and there's a whole lot more on the YouTube channel, but unfortunately we can't carry on. So firstly, I just want to say thank you to everybody who has clocked in from around the world and joined us. But secondly, Baris, this was just the most mind-blowing lecture. I really enjoyed it. Thank you very much. Yeah.
It's an honor to be here. Thank you, everybody listening me. Thank you very much. All have a good night.
Yes, have a good rest, and rest your voice tomorrow.
Okay, bye-bye. See you.
Bye, everybody.
Bye-bye.
Thank you.
Thank you.